Good evening, everyone, esteemed judges. Thank you for the opportunity. I'm Dr. Pranita SAHAY, and I'll be talking about the management outcomes of Tenon patch graft with cyanoacrylate glue overlay in moderate size perforated corneal ulcer. So perforated corneal ulcers can present with different size, shapes and positions and different etiologies, varying from infective keratitis to neurotrophic ulcers to PUKs and others as well. The management includes corneal gluing, patch graft and therapeutic keratoplasty based on the size and the location of the ulcers. Tenon patch graft is an autologous tissue and often comes handy when managing patients of perforated ulcers. It does not require an eye bank support and it does not require prolonged steroids as it causes less inflammation as in an autologous tissue. However, there are certain concerns because of the poor tectonic support and risk of leak and ectasia with the usage of this tissue. Hence, the purpose of this study was to evaluate the visual, anatomical and morphological outcomes of Tenon patch graft combined with cyanoacrylate glue overlay for moderate-sized perforated corneal ulcer. This study was conducted at Guru Nanak Eye Center, Maulana Azad Medical College. It was a retrospective study over 1 year time with the record review of the OT records and the MRD. Patients with perforated corneal ulcer size 3 to 5 millimeters were recruited who underwent Tenon patch graft with cyanoacrylate glue overlay and had a minimum follow-up records of 3 months. The primary outcome was a complete success, which was defined as anatomical integrity of the globe with graft integration, while the secondary outcome measures were the anterior chamber depth and the complication rate. A total of 25 patients were operated during the study period with a male to female ratio of 2:3. Mean age was 47 years and the cause for corneal perforation most common was sterile melt, being 52%, followed by infective keratitis, chemical injury and PUK. Among the patients with sterile melt, 2 patients had rheumatoid arthritis who had secondary Sjogren. Among infective keratitis, viral was the most common etiology, and PUK patients had history of tuberculosis and presented with flacular keratoconjunctivitis. These are some of the clinical picture of the patients who looked how they looked at baseline. Majority of the cases had a poor visual acuity with 84% patients having a vision of hand movement in PL at the time of presentation. 56% of the ulcers were central perforation and rest were peripheral and mid-peripheral. The mean size of perforation was 3.46, range being 3 to 5, and the distribution between 3 to 4 millimeter and 4 to 5 millimeter were approximately equal. 52% of the patient at baseline had a flat anterior chamber and others had a shallow anterior chamber. The fundus was normal in 3 patients where the fundus was visible, and CD was noted on ultrasound in 2 and CD with RD in 1 patient. Rest ultrasound was normal. Looking at the OT notes, surgeries were performed by 4 different surgeons. Surgery was done under mannitol cover under block anesthesia. The Tenon graft that was harvested was 1 millimeter oversized from the size of the perforation. Interrupted 10-0 monofilament sutures were applied. Cyanoacrylate glue and BCL were applied at the end, and the AC was formed with air in this procedures. However, in 3 cases it was noted that burying the sutures there was difficulty in burying the sutures. The mean follow-up was 8.7 months in these patients, and complete success was noted in 70.8%, and tectonic integrity was good in 95.8%. 1 case with pre-op had pre-op and RD and CD was excluded from the analysis. These are some on general analysis. It was found that those patients who were managed for PUK and peripheral perforated ulcers did well and had a deep anterior chamber, although there was focal adhesion of iris that was noted on the AIOS2025. And those patients in which they were managed for central perforations, although the graft integration was good, however, the anterior chamber remained shallow on follow-ups. And this was a patient of chemical injury who had a poor lid anatomy, had undergone previous AMG and SLET. In this, tectonic graft was done for a melt and perforation. However, at a 1 month follow-up, graft ectasia and thinning was noted both on clinical and AIOS2025 picture. This is another patient with a large graft, 5 millimeter perforation and graft that was done. On follow-up, thinning and ectasia of the graft was noted, and this eye ultimately developed staphylomas. The post-operative anterior chamber depth was well formed in 12% in 3 eyes and shallow but formed in others, and flat in 3 eyes. Overall complication rates were 28%, phthisis in 2 eyes, staphyloma in 5 eyes, and graft thinning and leak in 2 eyes with staphyloma, and re-intervention in the form of AC reformation in 3 eyes. Looking at the visual outcomes, 3 of the 25 eyes had better vision, better than 6/12, and all of these cases were perforated PUKs. Others had vision less than 1/60. AIOS2025 showed good graft integration in 23 of the 25 cases and graft ectasia in 2 eyes. The graft thickness, which records were available for only 10 patients, In the immediate post-op, the average graft was 328, and on follow-up it was 256 at the last noted follow-up. Comparison of the successful versus failure cases. There was no significant difference in the risk factors based on diagnosis site and size. However, for AC depth, the p-value showed a significant difference for diagnosis, wherein PUK patients performed better, followed by sterile, then infective, and then cases of chemical injury. In multiple and simple logistic regression analysis, there was no difference between the two groups in either the site size and perforation. And on review of literature, we noted that there was no graft dehiscence in our patients compared to other studies, and tectonic integrity was better. Hence, to conclude, the risk of graft dislodgement and was less in our study, and tectonic integrity was better compared to other studies due to the difference, probably due to the difference in the surgical technique, wherein interrupted sutures with cyanoacrylate glue overlay was done, and anterior chamber depth had significant association with the baseline diagnosis, wherein PUK performed better than sterile melt, followed by infective and followed by chemical injury cases. Thank you.
Nice series, Pranita. Just I have two observations. One is why have we not used overlay sutures? I mean, that seems to be working very well.
Yes. Yeah, so overlay sutures are also used by some, and we used interrupted sutures. The surgeons were comfortable with that, so it's a retrospective record review.
Right.
The surgeons used interrupted sutures in these cases.
Right. And second thing is, you noted 2 out of 25 cases graft ectasia, but 5 out of 25 is staphyloma. So
those
the staphyloma is not in the area of the
So the staphyloma is there, but the graft per se, the graft being ectatic and overall the eye developing a staphyloma is what we differentiated. Out of those 5 staphyloma cases, 2 patients predominantly had only ectasia over the graft. So
the others had beyond the graft as well.
Yes, yes.
So do you think that for very large grafts it may not still
it may not be good.
So maybe it may be good as a temporizing measure, but you have to do a keratoplasty sooner.
Ultimately. But
and one more complication which I think you should also note is the neovascularization, because that will preclude a future keratoplasty.
Yes. Okay.
What was the total follow-up of your patients?
So it was around 8.7 months we mentioned.
And did you correlate the underlying etiology with the success,
so we
or
compared
just the peripheral versus central?
No, we compared the chemical versus infective with the PUK and sterile with the multi-logistic and simple logistic regression as well. But there was no significant association in the overall success, that is the anatomical integrity. However, if we looked at the AC depth, it was better for PUK patients. The AC depth, the achievement of a well-formed anterior chamber depth was better in the PUK patients, followed by those patients who had a sterile melt compared to other cases.
Okay.
So, Pranita, basically you should highlight, as Rishi rightly said, that in such patients who eventually need a penetrating keratoplasty, the incidence of rejection would be much higher because of the vascularization that tends to come in. And so basically, I just want to understand, you did this technique in a center was done. It was the glue was used basically
for the tectonic support.
It provided a scaffold for the glue.
Provide a scaffold
for the glue.
Yeah,
right?
so it provides a tectonic integrity, because in the previous studies we have seen that the graft dislodgement and graft ectasia development of staphyloma are a few of the common complications, and the glue provides a good tectonic support over this Tenon's tissue, which is very friable.
And glue cannot, beyond 3 millimeters is very difficult to have glue hold on. So that's why you use it as a scaffold.
Yes.
And secondly, you mentioned that the graft thickness was 328 microns. By graft, what do you mean here? Just the
Tenon's graft.
Tenon's part.
Just the
You're
Tenon's
excluding
graft.
the glue, I hope.
Yes, because that causes it's a different reflectivity that we see on the AIOS2025. Yeah.
Is Ashish here?